Thank you for joining us for today's event on prior authorization overview. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. I'm also joined by other members of Provider Outreach and Education, as well as our prior authorization group. And those people will be helping me with the chat section and the Q&A for today's call. My objective for today is that you learn about the prior authorization programs that are currently in place by WPS, and that you as providers and suppliers get a better understanding about this process and what you need to do in order to submit a prior authorization request. We're going to achieve this objective today by reviewing both of our prior authorization processes. That is the Hospital Outpatient Department prior authorization process and the RSNAT, or Repetitive Non-Emergent Scheduled Ambulance Transport. We're going to also go over the documentation that's needed for submitting these requests, and we're going to then talk about some best practices of both services and some pre-submitted or frequently asked questions. We're going to start today out by discussing what prior authorization is and how it actually works under Medicare. Under the prior authorization process, the provider or supplier submits a prior authorization request and receives the decision before the services are rendered. So that's a basic definition of what prior authorization is. So it's a process that requires physicians or facilities or suppliers to obtain in advance approval for performing or billing the service. The process safeguards patients' access to medical necessity items and services while reducing improper Medicare billing and payment and helping to ensure overall compliance with the Medicare program. All of this is without changing medical necessity or documentation requirements. Let's talk about how it works a little closer. WPS has a process in place for providers and physicians or facilities to obtain advanced approval for the services that are covered under the prior authorization process. Providers have several opportunities in which to submit documentation and the prior authorization request in advance of the service. Now, these opportunities are via our provider portal, or you can submit via hard copy. And we're going to talk about that later in this presentation about how to submit these requests. After submitting the request, the MAC, or us, WPS, we're your MAC, we are then tasked with making a review determination and issuing a claim decision on the documentation and request information. We can make several different decisions based on the request itself and the documentation that was submitted with it. So a provisional affirmation is in essence a green light to proceed with performing the service and billing it to Medicare. A non-affirmed decision is a red light. It basically means that what you submitted doesn't support the medical necessity to proceed and have the services paid for by Medicare. Keep in mind, there's also what I like to refer to as a yellow light in these instances, and those are partially affirmed, where we can say some things are good to go while others are not. And we're going to discuss the review decisions again in a little bit. The other thing that a MAC issues with the review decision is a unique tracking number, or UTN. This number that basically follows that person and the decisions to the billing. If you receive an affirmed decision, you append that UTN to the billing claim, and that shows that you followed the prior authorization request process and you have a decision that says you've got a green light to proceed. Even if you get a non-affirmed decision and you wish to resubmit your request with additional information, you would submit it with that original UTN that was issued. Again, that unique tracking number is specific to that beneficiary for those dates of service for that supplier or that facility that requested it. So once you get the affirmed decision or the green light, that UTN then follows the billing claim, and it'll link all that prior authorization history. Remember, if you don't get a green light on the first request and you feel that the service is medically necessary and one that should be payable to Medicare, you have unlimited opportunities to continue to submit a new an additional prior authorization request with new or any additional information that you have. So I did touch briefly on the prior slide about some benefits of this program, but some of the benefits of the prior authorization process is that it doesn't change anything with medical necessity of the service or even the documentation requirements that support the need for that service. The only thing it really changes is the timing to support the services as medically reasonable and necessary. Other benefits is that it helps providers identify any potential claim issues early on so you can avoid denials. As a provider, you will know before you perform and bill the service to Medicare if you have everything you need. If you have everything you need to support the service as reasonable and necessary in advance of performing and billing that service. You still have to continue to support that service performed, though. Just remember, it doesn't mean that just because you got a green light to go with what you submitted in advance that you don't have to do any other work. You still have to document on your service when you perform your service and keep all your documentation of that service to support what you did, that it falls in line with Medicare requirements. This really helps to have some assurance of payment for you as a provider or supplier of this service. But I want providers really to keep in mind, again, it's not 100% guarantee that your claim's going to process without any issues. There are still claims processing rules that have to be met. There are still system drivers that the claim has to pass through, stuff like that before it reaches the payment floor. So if there's something that is billed or reported incorrectly when you go to bill the service, it could still hit a denial. I just want everyone to make sure that they're aware of that. Now, let's switch gears and discuss the different types of prior authorization requests. And we're going to start with the hospital outpatient department services. A little background on this. So through the calendar year 2020, OPPS, or Outpatient Prospective Payment System, and the Ambulatory Surgical Center Final Rule, which was CMS 1717, CMS established a nationwide prior authorization process. And they set forth requirements for certain hospital outpatient department services. This process serves as a method for controlling unnecessary increases in volume of these services. Now, CMS believes that the prior authorization of certain HOPD services is going to ensure that Medicare beneficiaries continue to receive their medically necessary care while protecting the Medicare trust fund from that improper payment. And at the same time, again, keeping the medical necessity and documentation requirements unchanged for our providers. So who does it apply to? This process applies to outpatient PPS, prospective payment system hospitals that are billing on a type of bill 13X. So these are facilities, not Part B physician offices. This process does not include ambulatory surgical centers or ASCs, physician offices, critical access hospitals or CAWs, or rural health clinics or RHCs. If you perform these services on and you're billing on any other type of bill other than an outpatient PPS hospital type of bill, again 13X, please do not submit a request for prior authorization. This only wastes your time and our time as well, because our review nurses then have to take the time to decide if the review needs to go on or if it needs to be dismissed. If it's on a type of bill that's not under this prior authorization process, then it needs to be, dismissed by us. On this slide is a list of services that are currently performed in the hospital outpatient department that would require prior authorization. However, providers should keep in mind that not all CPT and HCPCS codes that match the description of the services require prior authorization. We do have a full list of codes that do require prior authorization. And again, you can find those at the link here that's on the bottom of your slide. And I am just going to quickly link out and show you that. And we're going to go back and forth to the WPS website probably a few times. But, this one took you to the CMS list. But here are all the codes for HOPD services that require prior authorization. Again, you can link out to this on your own time, but I just wanted to show you. So if you are doing blepharoplasty, blepharotosis repair, brow ptosis repair, and the CPT code is not one of these, it does not need to be submitted for a prior authorization request. Now I'm just going to go back. I do see a question came in. Can you confirm that we do not need to submit any prior authorization requests for physician offices / behavioral health? Not under the hospital outpatient department prior authorization process. So these are the only codes, and these are only for facilities that bill on a type of bill 13X. The physician's offices, they can proceed with their billing on their end if they perform one of these services. This again is just pertinent to the hospital outpatient, and you're very welcome, Vanessa. Okay, let's move on. On this slide, you're going to see several links that are going to take you now to the WPS website, where you can find additional information about these services. So this includes documentation requirements, submission forms, information on how to submit via the portal, via hard copy, etc. So using the first link in here, the HOPD one, I'm going to take you to the WPS website and show you where you can find this information. Again, Part A process. Now, you can see I've already gone to J5 Part A, but if you come into our website, one of the first things it's going to ask you is which part and jurisdiction. Since these reviews are specific for facility, it would be J5A or J8A. I'm going to then go to the topic center, and I'm going to select medical review because it's a medical review process. We've got a quick link for you right at the top of the page that's going to take you to the overview. Otherwise, you can scroll down to prior authorization. But I'm just going to go ahead and use the quick link, and it's going to take me right to where the link in the PowerPoint took you to. Now, as you scroll through here, you're going to find all the information about the various reviews that fall under this prior authorization process, including the list of codes. So here's that bleph repair, brow ptosis repair that we talked about. And then under that, it's going to give you the information about any documentation that needs to be submitted for that claim review. If we have a local coverage determination, it's also going to provide you a link to the local coverage determination where you can get additional information about coverage of these services. So again, it goes on and includes, this overview includes all of the services that are currently under review under this process. And I'm going to scroll quickly, but then you can also see after you get past the services, we have information for you on prior authorization requests and documentation submission. We'll talk about it again a little more as we go through, but the best way to submit is via the portal. So if you are a physician office and you are requesting a prior authorization on behalf of a facility, which is allowable, you don't need it for your billing, but the facility needs it for their billing, and maybe you want to submit it because you have all the documentation to help support it. So you're doing it on behalf of the facility. You won't have access to do it via our secure portal because you don't have access to that facility's portal. So you then would have to follow one of the other processes in which to submit, which again, you have several options. You can send it via hard copy. You can send, through the mail or like UPS or FedEx. You can send it via fax, which is probably your next most easiest way to submit. Or again, you've got hard copy options again. So that is a quick overview on that. We're going to go back to the PowerPoint, but before I do, if a HOPD prior authorization request is rejected due to wrong jurisdiction, what should the provider confirm to determine the prior authorization is being submitted to the correct MAC? Would that be the hospital PTAN or the NPI? Unsure why the prior authorization was rejected because the hospital appears to have home address within the jurisdiction. So, Tracy, you would need to verify that your facility is under WPS. So if you are Nebraska, Iowa, Kansas, Missouri, you are J5. If your hospital is Nebraska, Iowa, Kansas, Missouri, you're J5 Part A. Indiana or Michigan would be J8 Part A. And if you are in any of the other states that we still do some Part A services on, that would fall under J5 as well. So any question about choosing the right jurisdiction in your hospital and stuff, you can always ask that of our customer service line as well, just to verify. But your billing department should know which MAC, and you just have to verify that you're submitting it to the correct MAC. All right, I'm gonna go back to the presentation. Let me get that pulled up. There we go. The other thing that I forgot to show you why it was out there was the request form. And we're going to talk about that request in a little bit here as well. But one of the things that is available for our providers that have to submit via hard copy is the request form that you should be using. So if I go back out to just our home page, here's the easiest way to find the request form. You choose your jurisdiction, whether you're J8 or J5. You're going to choose tools, all tools, and we're going to choose all forms. And then we're going to scroll down, and we're going to see the prior authorization request form, and we're going to open that, and we're going to download it. And when we download it, then you have all the information. And this is crucial, as Tracy had pointed out, because it's going to delay your review if you send it to the wrong place. So you want to make sure you are submitting correctly. And if you're going to fax, we have the fax numbers listed up there for you. And you can see that they're different because they go into a fax scanner where that information is stored. So again, we want to make sure you complete those correctly. If you submit via the portal, all of this information besides the fax number, because you're submitting via the portal, all this information is part of what you submit on the portal before you load your documentation. And again, we're going to go back to that and look at that again after a little while. But moving on, we're going to switch gears now, and the next prior authorization process I want to talk about under Medicare is the repetitive scheduled non-emergent ambulance transports, or AKA RSNAT. A little background here. Just as we discussed the hospital outpatient department background information, I want to discuss the RSNAT background information as well. One thing that's different about prior authorization of RSNAT services than HOPD services is that the RSNAT is voluntary. However, I say that, but there's always a caveat. If an ambulance supplier elects to bypass prior authorization of applicable RSNAT claims, those claims will be subject to prepay medical review, and they could be subject. So claims for the first 3 round trips, those are permitted to be billed without any prior authorization and without being subject to payment, to prepayment medical review. Any trips after that, however, are going to hit for mandatory medical review. So it's just a good idea if you have a beneficiary that you know you're going to be providing repetitive scheduled non-emergent ambulance transports for, that you just go ahead and submit the prior authorization request. Most of those repetitive scheduled non-emergent ambulance transports are people that are probably going to have way more than 3 round trips with you. So anyways, in 2020, CMS announced it's going to expand the RSNAT prior authorization model to be nationwide, because it was a trial to start out with just a few MACs looking at that. But back in 2020, they decided again to make this permanent and a nationwide process. So the process started for WPS back in 2022. Just as with the HOPD prior authorization services, the RSNAT prior authorization services help ambulance suppliers ensure that their services comply with all those applicable Medicare coverage and coding and payment rules before the service is rendered. So who does this process apply to? RSNAT prior authorization process applies to Part B ambulance suppliers that are rendering repetitive scheduled non-emergent ambulance transports for Medicare fee-for-service beneficiaries These are not ambulance suppliers that are institutionally based. These are for claims that are billed on a CMS 1500 form or an 837P electronic equivalent. If you are a hospital-based ambulance provider that is providing RSNAT services, you do not need to submit for a prior authorization request. So if it's going to the Part A side of Medicare, you don't need to submit. If it's a Part B and you are an ambulance supplier that's not institutionally based, this process does apply to you. I want to take a few minutes and help you understand how CMS defines some ambulance services. So the non-emergent ambulance transport is defined as a transport that is appropriate if either the patient is bed confined and other methods of transportation are contraindicated for that patient, or the beneficiary's medical condition requires transport by ambulance regardless of bed confinement. CMS further defines bed confinement as the patient's unable to get up from their bed without assistance. The patient is unable to ambulate, and the patient's unable to sit in a chair or wheelchair. So that's one thing to really keep in mind, you know, if they need ambulance transports, are what the criteria of bed confinement is. CMS defines repetitive ambulance services as those services that are medically necessary transport. So remember, ambulance is a transportation benefit. Medical necessity means that the transport by any other means would be contraindicated for that patient. Repetitive ambulance transports are also further defined by those trips that are furnished in 3 or more round trips during that 10-day period of time, or at least 1 round trip per week for at least 3 weeks. So for example, these would be transport services that often needed by a beneficiary receiving things like dialysis or cancer treatments that you know are going to go multiple times throughout the week, throughout the month, etc. In order for Medicare to cover RSNAT services, the first thing that must be met for use to consider the transport is that the service is medically necessary. And I've said that several times, and I said that that means that it's contraindicated by any other means of transportation are contraindicated. So it's defined in the 42 CFR 410.4. The Benny's condition must require both the ambulance transportation itself and the level of service provided in order for the billed service to be considered medically necessary. Non-emergent ambulance transport is appropriate if either the beneficiary is bed confined and it's documented that the beneficiary's condition is such that any other means of transportation would be contraindicated, or if his or her medical condition, regardless of bed confinement, is such that transportation by ambulance is medically required. So thus, bed confinement is not the sole criteria in determining medical necessity of ambulance transport. It's just one factor that's considered when medical necessity determinations are made, either on your end as a supplier and also on our end as the MAC. Additionally, there's some special rules when it comes to non-emergent scheduled repetitive ambulance transport services. And again, those are in the Code of Federal Regulations. And I'm just going to plop that Code of Federal Regulations into the chat, even though it's listed here on the slide for you. but I want to make sure you're aware of where to find this information. So again, special rule for non-emergent scheduled ambulance transports. So Medicare covers these medically necessary RSNAT services if the ambulance provider or supplier, before furnishing the service to the beneficiary, obtains physician certification statement. And that statement needs to be dated no earlier than 60 days before the date the service is furnished. In all cases, the provider or supplier needs to keep that appropriate documentation on file and submit it upon request to us. So again, we're using the information in the Code of Federal Regulations when making our review determinations. So we need to see that there is a physician certification statement when you plan to schedule these services, and that physician certification is dated no earlier than 60 days. Just as with HOPD services, prior authorization for a RSNAT service is subject to specific codes provided by these non-facility-based ambulance suppliers. So these are on your screen, and they include the A0426, which is that ALS non-emergent, the A0428, which is the BLS non-emergent. It does not include ambulance mileage code. If you request a prior authorization of any code that's not listed here, it's not going to be reviewed and it's going to be dismissed. So again, only these codes are specific to these processes. So let's move on and talk about how to submit these requests. There's several ways, again, I mentioned earlier, to submit a request. The first and most recommended is via that provider portal. So when you go into the portal, the information starts with and looks kind of like this, and you're going to click on the prior authorizations in the transaction section of the portal, and it's going to bring up the information you need to put in about your beneficiary, about your facility, about your transport, about your HOPD service, etc. So again, portal is the most recommended. Let's see. There's specific rules. So again, you have to have access to the portal. So if a hospital or physician office plans to perform an HOPD service that's on the list, they can submit on behalf of that hospital if they want. However, since this is specific to the facility, they're not going to have access to the facility's portal. So they have to submit in a different manner. The physician does not need a prior authorization for their billing. They do not need the UTN or the unique tracking number from the facility for their billing. The process itself, again, is on the facility for HOPD services. The other option for submission includes hard copy. Again, this could be via mail, via fax, via ESMD, etc. When you're submitting hard copy, you must also complete a request form. And those were the forms I talked about earlier, but let's go ahead and link back out to our website really quick. And I am going to just go back to the main page. So first, let's take a look at HOPD, which we did already once, but again, we're going to go to Tools, All Tools, we're going to scroll down to All Forms, and we're going to open the prior authorization, and we're going to download that, and we're going to complete all the required information. So we need to know if this is a first, an initial, or a resubmission. Because remember, you have unlimited amount of times to request a prior authorization review. If you're doing a resubmission, what was the UTN that you got from the initial? If it is an expedited request under HOPD services, you need to explain why it needs to be expedited. And just so you know, expedited requests are not for convenience or billing purposes, time frames. You're getting close to when the doctor wants to do this. It is if the time it takes us to do a standard review places your beneficiary's life at jeopardy. Those are the only times you should be submitting an expedited review. Again, you would fill out the facility information, physician information, and then again, what CPTs, modifiers, and then any additional information. Now, this is key. We've given you some hints about things that are often missed, that it is only going to behoove you to add that additional information in here. If you're doing a vein ablation, we need to know the vein location, which leg, which, what part of the extremity, what vein. Is this a diagnostic or therapeutic injection? Is it MBB or IA? Those are just some of the hints, but paint the picture for us. Let us know. Some codes are the same for some services, so we need it further defined here. And then how do we get a hold of you? Who's requesting that? How do we get a hold of you, etc. As I go back out to the website, I'm going to switch to Part B. And actually, we're going to go back out just like you were coming in brand new, and I'm going to go to J5 Max Part B. I'm going to go to Tools. I'm going to go to All Tools again. I'm going to go to All Forms. And again, I'm going to scooch on down to Prior Authorization, and you can see here's the RSNAT one. And I'm going to open that if my computer plays nice. And I'm going to open there we go. And then I'm going to download that one. Again, now a little bit additional information, different information on Part B and for RSNAT services. Again, is it initial or resubmission? And then we need to know the number of transports requested. And that's in round trips. How many are you doing? Or I should say a round trip equals 2 transports. So you need to let us know the total number of transports that you are providing. We need to know the time frame here and then which procedure codes you're billing, as well as any modifiers. And then again, supplier name, beneficiary name, certifying physician name, and then how do we get a hold of you if we have questions? Who is requesting this? And where do we send, who do we send the information back to? So those are the 2 easiest ways to find the hard copy one. If it is being submitted via the portal, you can use our portal user manual, and you can scroll down and you can find the information about prior authorizations down here. And then again, this gives you information about where you're going to find it in the transactions, what certain fields are going to look like, etc. So if you're not familiar with submitting via the portal, I do encourage you to go out and take a look at the provider user manual before you submit in that way. All right. Going back. Got to move on in the interest of time. Now, I showed you when we went to those different overviews where it gave you information on documentation requirements. So I'm not going to link back out and show you that again, but I wanted you to be aware that if you are going to submit a request for prior authorization, that you do go out, take a look at our site, take a look at the overview and make sure you're hitting all those documentation requirements for the type of service you are performing. So now that we've talked about the background and the process and the codes that are subject to review and how to find the documentation to submit, let's turn the tables a little and talk about the review itself. All right, I want to talk about how this review process works. First, after we receive the request for prior authorization and the documentation to support the service, we as your MAC, we have seven calendar days in which to make a decision. As we talked about earlier, there's several types of decisions that can be appended to your request. So again, those review decisions include your provisional affirmation or your green light, go ahead and perform and bill it, your non-affirmed or your red light, and then there's also rejected. And rejected requests are invalid requests, those things that we have to dismiss because they're not part of the process or they don't meet the prior authorization process requirements, like a physician office that submitted a HOPD request. That would be dismissed. I talked about this briefly, but I just want to hit it again. HOPD prior authorization requests also give providers the opportunity to request a review to be expedited. Again, if that time frame that's allotted for a review decision, that 7 days, would seriously jeopardize the life or health of the beneficiary. True expedited reviews are few and far between. But when we do receive one, we have 2 business days in which to make a decision. So regular reviews, we have 7 calendar days. Expedited, we have 2 business days in which to make that decision. If an expedited review request is submitted and it's invalid, so it really was only requested because the provider scheduled the procedure for 2 days from now, it's going to be converted back to the standard time frame of 7 calendar days. So only those true expedited requests will receive an expedited review. We've talked about the different types of decisions a few times now, but on this slide, this just helps to define the meaning of these decisions. But what I do want to do today is to link back out to our website and show you how you can look for a review determination if you have the necessary information. So I'm going to go back out to our website. Give me a second here. I'm going to go back in just like I'm going in brand new. I'm just going to choose the J5 Part A. And I'm going to go to this quick link over here. This is the easiest and fastest way to do it. And go to the prior authorization search. Here, you're going to have to fill out some information. And then you can see you can, if you complete this, you can check on the status and information on your prior authorization request for your specific beneficiary if your request has been submitted. Again, if you have access to the provider portal, that's where you want to go. You want to log into your provider portal. You want to make sure that you are looking at the claim itself, any review determinations. You can see any letters that are appended to that determination, etc. But here's a quick way to find out the information that you might be waiting on. All right, so I'm going to go back out. Make sure to wait at least 24 hours. Remember, we have up to 7 days to make a review determination. Our prior authorization request, or prior authorization team is good. They are fast. They make them before that 7 days generally, but you have to give them time to make the request. You can't just put it in and check 24 hours later and expect, you know, everything's going to be in there for you. All right, and then again, I'm just going to briefly hit a few more things about those review determinations and what they mean. So when we issue a provisional affirmation or that green light, we're going to send you a letter with that UTN. We're going to send it via fax or mail and put it in the portal. However you request it is how the notification is going to go back. It's always going to be in the portal for you, but if you request via fax, we're going to fax you back that decision as well. So again, if you don't have access to the portal and you're going to still get that decision in several different ways. Once you receive your provisional affirmation letter and unique tracking number, you can go ahead and render the service and bill to Medicare. You must still maintain all of your records and support that the service continues to be medically necessary and done in accordance with Medicare standards. Be sure to append that UTN number to your bill. Now, your UTN for HOPD services is valid for 120 days. In RSNAT, the services we're affirming are in 60-day blocks. And if the authorized number of trips is not used within that 60-day period, you can't carry them over to the next block or time frame or next number of trips. Non-affirmed decisions are still going to get a notification of the decision in the same manner as the affirmed decisions. The difference is that the decision will tell you why your request was not affirmed. So just as with those affirmed decisions, the beneficiary is also going to be notified via mail as well. I cannot stress enough that this is not a denial. This is a pre-procedure, pre-service review that ultimately gives permission to perform and bill the service to Medicare. So if you do receive a non-affirmed decision and you have additional information that supports the need for the service and you believe it complies with Medicare program services, you can simply submit another review determination to be made. You can do that as many times as you want. But remember, as I said back in the beginning, that UTN that we issue, even if initially non-affirmed, that follows that beneficiary's request. So each time you submit this request, you need to include that UTN from the initial decision. If we do issue a non-affirmed decision and the provider proceeds with performing the service and billing it to Medicare with a non-affirmed decision and UTN, your claim will deny. I keep saying that you can resubmit if you get a non-affirmed decision, but let's talk about why this may happen or why you would choose to resubmit. First, maybe there was an error on your first request. Maybe you requested the wrong CPT code. Maybe the codes got fat-fingered. Maybe there was a minor omission in the documentation that's submitted. For whatever reason, you're going to submit again. You need to include all of the original documentation that you first submitted, as well as any new documentation to support your request as reasonable and necessary. You should continue to provide any medically necessary services to your patient while you're awaiting review determinations. But don't submit a claim for payment until you receive the decision, because you need to append that original UTN to the claim. In the event that we do reject a request, we're going to notify the supplier or facility of why it was rejected. You need to review the rationale and correct any errors before you resubmit another request, or before you keep submitting requests that continue to be invalid. If you receive a rejection because it doesn't meet the requirements of the process and you make corrections and you want to submit it again, then you should treat that request as another initial. So if it was rejected, not non-affirmed, if it was rejected, but it was rejected because maybe you didn't submit it right. You submitted it as a physician office and you really should have been submitting on behalf of the facility. Then you request, but that would be an initial request. So again, it would not be subsequent at that point if it was prior rejection. UTN. So I briefly discussed these going all the way through. That is that unique tracking number that follows that patient. Just to reiterate, for HOPD, it's valid for 120 calendar days, and you've got to include it on your institutional claim. For RSNAT, that UTN is valid for that affirmed time period. Remember, you had a date range that you needed to supply to us for which you were going to do these repetitive transports. New UTN needs to be obtained for each 60-day period. I highly suggest that when you're about 2 weeks out, that you request your new UTN. Again, and it must be included on that 837P or professional claim. So for HOPD, there is an exemption process. So before I talk about some of those common questions and errors, I want to discuss the exemption or exempt process for hospitals that are subject to HOPD services. If you are a hospital that demonstrates compliance with coverage and coding and payment rules related to those prior authorization services, you may be eligible to be exempt from having to request prior authorizations. So during the standard review timeframe, we as your MAC, we monitor all providers that submit prior authorization requests. If during these timeframes, your facility has submitted at least 10 prior authorization requests and achieved at least 90% provisional affirmation or green light on the initial request, so 90 or greater, you could be exempt from having to submit requests for HOPD services that are listed in the prior authorization process. If we determine you meet the exempt standards, the exemption will remain in effect for a 12-month period. So this applies to all services that you provide at your facility that fall into the HOPD exemption process. So I'm going to end with some common provider questions that we always get. I know we're running close to time, so I'm going to go through these kind of quickly. The first one is for HOPD, if a physician office obtains the request, will that cover both the hospital, so the facility, and the physician? So again, it's not necessary for the physician's billing to have a prior authorization on the physician's service. The process in HOPD is specific to facility only. The physician does not need a UTN in order to bill for their services. It's only pertinent to type of bill 13X hospital outpatient department services. Those are the only ones that require the prior authorization and UTN. So someone put in a question, what are the steps if when we get an approval for services, however, during the provider aborted during the procedure and performed HOPD that needed a prior authorization as well. So there are services that could be one thing and could be another. In those cases, not all of the services that fall under the HOPD prior authorization could potentially, let's say, go from a closed procedure to an open procedure. But there are some of those procedures that are listed that could change. If you believe before the procedure is done that your procedure has a probability of changing, maybe from an open to close, or maybe from one type of that procedure to another type, we highly encourage you to put both of those CPT codes on that initial request. If you perform something, and I'll circle back with Candy and have her bring the, or chime in as well. If you perform something and it wasn't prior approved, you didn't get that green light, it's on this list, and you bill it to Medicare, it's going to be denied, I'm pretty sure. Is that correct, Candy?
So if it would get denied, at least then you do have appeals rights, okay, at that point. So because then it would be a claim denial, not a prior auth denial. So then you do have the option where it could still be approved. Like Mary Sue said, if you think, let's say like a paniculectomy, there's a couple of different codes. If you would think you would need one or the other of them, or you could get in there and you might need both, put them both on the PA form and just describe that. We have that sometimes with rhinoplasties as well. So you are allowed to ask for other codes if you think you may need them.
Thank you so much, Candy.
You're welcome.
All right, I see another question came in, and if a patient goes into the hospital and you had an active RSNAT, how long can they be out and not getting transport before we need another RSNAT prior authorization? So in your initial request, you put a date range of when you were going to provide that 60 days of transport, or up to 60 days. If you're going to go beyond that, you will need to submit another prior authorization request for RSNAT. So keep an eye on those that you are transporting repetitively, and if they are out because they are hospitalized, keep an eye on your end date of that, and if you're within that 2 weeks, I would do another request for that next set of transports. All right, moving on, and in the interest of time, I want to be cognizant of everyone's time. I appreciate anyone that is able to stay on for the remainder of the webinar, but if you are not able to stay on, I understand if you need to disconnect. I'm going to have Jennifer throw the survey link in there in the chat, and I do encourage you to take our survey, but again, thank you for those of you who are able to stay for a few additional minutes. If you're not able to stay, the remainder of these question and answers are going to be in the encore that will be posted to YouTube, and it will be available later today. So under question 2, for HOPD, if a physician office obtains the prior auth, oh, we already went through that. Will that cover both the physician and the facility? And the answer to that is that the physician office doesn't need that. All right, why are only certain services included in prior authorization? So CMS determined that. CMS started with certain HOPD services that could pose the greatest risk to the Medicare Trust Fund if they're performed for reasons other than what's considered medically necessary. Other services have been phased in since the start, so CMS may choose to continue to add services. At this point in time, we do not know if there are any other services that are on their radar. Question 4, can providers appeal a prior authorization decision? And we've alluded to this, and the answer to that is no. A prior authorization request itself is not appealable, as there's no denial on the claim at this point, because these decisions are prior to the performance and billing of the procedure or the RSNAT services. So there's nothing to appeal. As Candy had said, if it goes through to billing, something happens, or even if it hits a driver going through the claims processing world that causes the claim to deny, providers then would have the availability to appeal anything that gets a formal denial. But in the prior authorization process itself, those are not denials, those are just non-affirmed decisions. Next question, for RSNAT services, can our company assume another ambulance supplier's affirmed decision if we are now going to be the supplier performing the transports? And the answer to that is no. The new supplier would need to obtain a prior authorization. If the initial supplier cannot complete the total number of prior authorized transports, like maybe the initial ambulance company closes or they're no longer servicing that area, the initial provider must relinquish their UTN before the request is canceled. So in this situation, subsequent ambulance supplier may submit a prior authorization request to provide those transports for that same beneficiary and must include all the required documentation in their submission. If multiple ambulance suppliers are providing transports to the beneficiary during the same or an overlapping time period, the prior authorization request will only cover the supplier for whom the request was made. Applicable RSNAT claims submitted for which no prior authorization request is recorded will be subject to prepayment medical reviews. And then moving on, question 6, for HOPD services, can we extend a prior authorization decision if the patient's procedure is delayed? So again, that affirmed decision and UTN are good for 120 days. If the procedure is delayed past that time frame, the provider would then need to submit a request with a new anticipated date and service noted and make a new request for their new dates. And then finally, for RSNAT services, if we know we're going to perform more than 80 one-way trips in a 60-day period, can we submit multiple requests at the same time? And the answer to this, again, is no. Only one request can be submitted at a time. Providers can request up to 40 round trips or 80 one-ways in that 60-day request period. Transports that exceed those 40 round trips or 80 one-way in 60-day period, those are going to require additional prior authorization requests. We encourage you, again, to submit that within, about 2 weeks. Now, there is a provision in the regulations that allows us as your MAC, when we see that you've submitted several requests for the same beneficiary, and we can see in your documentation that this is someone that's going to be going a long period of time, we have the availability to allow for 180 days. But that is a MAC decision, and that is not something that you as the provider could request. All right, which takes us to the end of our formal presentation. Again, in the interest of time, I don't see that there are any additional questions, but if you have additional questions and we didn't get to them, I do want you to send them to our education mailbox. Now I'm gonna have Jennifer just throw that education mailbox in the chat again, and I will give those answers. If any questions come in, I will send them via email out to everyone. So we're gonna skip the question and answer portion. Again, I appreciate any of you who were able to give me a little bit of additional time. We value your opinion. We wanna hear from you on how we did on this event. So there's gonna be a survey. Jennifer's put that survey link, that feedback link into the chat. When you close out of the webinar, it's also going to redirect you to the survey. We do ask that you complete it. We want to know if this was valuable for you. Make sure you read all the questions, you read their responses, make sure if the ranking has changed, you understand it, because we all get a little survey fatigue. And so it's easy just to go through and click 55555, but the ranking may change. So we just want to make sure that you are aware of that. All right, and finally, again, if you think of any questions, put those in that email address, send them to us, and I will be sure to put out the answers to everyone. Make sure you do not send any PHI or PII via email. And remember, we do not have access to the claim processing system. So if you need to find out something about a specific claim, you will need to take those questions to our customer service department. Remember to check the notes section of the slides for any additional information, including CEUs. That information is in the additional information of your slide. So on behalf of Jennifer and myself, as well as Medical Review, I want to thank you for participating in today's event. This concludes the webinar, and you may now disconnect.